Welcome to the very first episode of Lessons from the Lab. My name is Devin Rubin, and I will be hosting this episode. This is an educational session in which I have brought a couple of guest experts to join me and discuss a topic that we encounter in the EMG laboratory. The goal of this is to have a conversation and discuss some practical aspects to the case, to provide some educational material for all of the viewers and also for me. It's helpful for all of us when we are practicing electrodiagnostic medicine and neuromuscular medicine to hear from the experts, to think about these cases, to improve our practice. And that's what this is all about, to chat a little bit and to learn a little bit. So let's get to it and bring in our wonderful guests. Well, welcome. It's a pleasure and an honor to introduce our guests for this first Lessons from the Lab, Dr. Larry Robinson and Bill Litchie, otherwise known by some as Spike and Wave or Wave and Spike. Welcome, guys. Good to see you.
Thanks for having us.
Yeah, we're glad to be here with you.
Yeah, I appreciate you taking your time at the end of probably a busy day for all of us. And it's been a little while since I've seen you. I think we were in Nashville, right?
We had a really fun time in Nashville. We had so many great poems come up at the meeting, and we had a terrific session with ultrasound and waveforms.
Yeah.
The only thing that concerned me, Larry, was the demand for hats. They were attacking us to get hats. And
I was wondering the same thing. Those have been pretty popular, more and more each year.
Yeah, I think that we even got a letter afterwards, someone explaining why they deserved a hat and didn't get one.
We did.
Did you respond?
I didn't, but Larry did, he says.
Oh, okay.
I don't think so.
You guys have been doing EMG Talk for how many years now? Do you remember?
It's over 25 years, although we had a brief hiatus. I don't remember what year we started, Bill. It must have been 1994. Yes.
Because we stopped in 2014.
Yes.
And we also have done it in Spanish and as well as English. And I think we're up to do another one in Spanish next year, I think. I'm not sure of that, but that's
we have. We've gone to Mexico to do it in Spanish. I also went to the UK and did one with Jeremy Bland they don't know what car talk is. So we had to do Gardner's time, and I had to learn how that worked in the BBC system. Yeah, so it's been a long time.
So when at 94, I was walking when I was in 94, but I wasn't there. But I've been to a lot of them. And I have to say, I think this past year would make your greatest hits album. I thought it was a great one. And I don't know how you felt, but I thought it was fantastic. And I'm just curious, when you do EMG Talk, what do you enjoy the most, or what do you get the most from it yourselves? You're obviously teaching others and entertaining others, but what do you get from it?
I'll start, Larry.
Yeah, go ahead. Yeah.
I think the important thing to me, there are two things. One is using humor increases the ability for people to learn. I think they remember things with humor a great deal. One of the reasons that we started this, at least in my mind, is we wanted to get experts in the room with us, that we could get a little loose and a little relaxed, not their steadfast old ways, and get them to talk about things of importance. And that has been a theme that we've tried to keep through the period of time. Sometimes have been more successful than others.
Yeah, I agree. That's what I get too, Bill. And I love the social cohesion that we get. How everyone is there, they're learning, they're having a good time. We have guest stars like yourself and Michael Cartwright. We have people reading their poems this year. I love that part, and limericks. And it's more like a big happy family learning together. I love that. And I love the way that Bill and I play off each other. We play off our guests and off the audience. And it's really a way to try to show off our creativity.
Yeah. Oh, go
I
ahead.
think part of the success is the fact that the way Larry and I play off of each other. I think that really has added a lot to it. We went into this saying we may say things about each other in public, but we both have thick skin and we understand that. And I think that's worked well for people to see that.
Yeah, and you know, as an outsider, you know, I agree, and I think anyone who hasn't come to EMG Talk, and this is not an advertisement show for your EMG Talk, but I think it really is a highlight of the annual meeting. And as you both said, I think what I noticed this year was that people did seem to be more engaged. It was throughout the whole room, there were people chiming in, and maybe it's because they wanted the hats, but they really seemed involved and like they were having fun. And you really did a great job engaging the audience, as you always do.
That part of that technique is that roaming in the audience, it really makes a difference. And looking at someone's eyes and say, you know, they really want to say something, but they're a little shy. But once you get in get the microphone in front of them and make sure they're going to say something, they really come out with some good things.
Yeah.
I mean, I've learned from these sessions, and Larry's so smart, maybe he hasn't, but I have learned. Every year I learn something.
And that's what it's all about, having fun and learning. And yeah, you know, I think people learn, maybe don't even realize that they're learning because they're having so much fun, but they leave and say, oh, I didn't realize this, or I think about something a bit differently. So,
and it's also a chance to show off the thought process in our minds. You know, in a standard lecture, we just present the data. This is the way it is. This is the differential diagnosis. But now we present a problem or an ultrasound image or a waveform. We all think through it together. And that thought process really is helpful to showcase in public.
Yeah. Well, that's, oh, go ahead, Bill.
Historically, one of the things we wanted to do was educate. But I remember after about the third time we were doing this, I was saying, are we really educating? And I remember clearly walking out of the room with one of the people that I think most highly of as an EMGer in the world was there. I won't name him. And we were walking out and he was saying, well, that was a lot of fun, but I didn't learn a damn thing. And we walked a few more steps and he says, now, wait a minute. I didn't know this that you talked about. And I thought, if we could teach that person something, then it is educational.
Yeah. And sometimes it does take walking out of the room, thinking back about the evening to realize, hey, you know, I didn't understand it, or I thought I understood something and now I understand it better. So speaking of educating, that's a great segue into why we're even here, because we could talk about EMG Talk for the next 2 hours. But the goal of this Lessons in the Lab episode is for us to teach each other or learn from each other and teach our audience just something maybe simple. And what I'd like to do is just spend a few minutes and present a case to both of you that we had in our lab. It's a pretty straightforward case, but I'd like to just kind of do what you just said and go through your thought process and how you might approach this patient, or what you might do different or separate from what we did. So I'm going to actually share my screen. It's just one slide. The case, I'll tell you the case. It was a 45-year-old woman who was referred for hand pain and hand numbness, and her symptoms were there for, I think, several months. She had kind of vague symptoms. She said that her hand, she had discomfort kind of throughout her hand. She had some numbness in her hand, particularly at night. She would wake up and shake her hand. Sometimes when she was texting, her hand, it was her left hand, it would become numb. She didn't really have any neck pain or any more proximal symptoms, and didn't have any symptoms in her right hand similar. It was just the left side. So, and her exam, her basic neurologic exam was normal. She had normal strength, normal reflexes. Her sensation was pretty normal in her hand. There was no obvious sensory loss. So as I don't have to ask you what you're thinking, but she was referred for a question of, does she have carpal tunnel syndrome? Was the referral. So I'm going to just show you the 3 conductions that we did. Let's see if you could see this. So can you see this slide?
Yes.
So it may be a little bit small, but this was her left hand, and so we performed a median motor conduction study, and everything was normal. Her latency was within normal limits. And then we did orthodromic palmar studies. The top is the median and the bottom is the ulnar, and just stimulating in the palm, recording at the wrist. And her latencies were 1.55, I believe, and 1.6 for the ulnar, and her amplitudes were normal. So she basically had normal palmars and a normal median response. So the question I'm interested in, what you're thinking, or in this scenario, would you be, and her needle exam was normal. So she didn't have any findings, screening hand and several muscles that are supplied by different roots. So my question is she sent for carpal tunnel? We did these studies, doesn't show any abnormalities. Would you stop, or would you do anything else, or what would you do?
I can go first if you want.
Sure.
Pretty normal looking studies. I would traditionally do, and I'm not sure it would add a lot, the combined sensory index. So that would be to look at the mid-palmar difference and then add into that the difference between median and radial to the thumb, plus the median and to ulnar to the ring finger. So add those 3 differences together, and the sum of the 3 differences should be less than 1 millisecond. Just looking at the mid-palmar, and we've looked at this and published on it, given essentially a 0 difference there, it's unlikely you're going to have a positive CSI. So I'm guessing that this is still going to be a normal study. No test is perfect, and the sensitivity for nerve conductions in carpal tunnel syndrome is not 100%. So it's possible that she still has some irritation in the median nerve that would warrant some conservative treatment, but I don't think she's a candidate for surgical release.
So just before you chime in, Bill, when you talk about the CSI, I'm just going to flip here. So this is what you're talking about. I had a feeling you might say that. So I made a slide. So, and for the viewers, just who aren't familiar, I think if just to confirm, this is what you mean. So this is what we performed with our palmars.
Yes.
Median ulnar, and then this is, you're saying, record ring finger and stimulate the ulnar, or the median, and then the ulnar at the same distance, and then the thumb stimulating radial and median at the same distance.
Exactly, yeah. So you do these 3 tests, add the 3 latency differences, median minus ulnar, median minus radial, plus median minus ulnar, and the sum of those 3 should come to less than 1 millisecond. And that adds reliability and sensitivity compared to doing just a single test. It's just kind of like if you take your board examination, you want to have multiple questions and get a summary number, your average percent correct. And here too, if you're going to do multiple tests, it's better to add those 3 together and get a reliable number at the end. So that might be positive. Some tests, sometimes you would see results that are sort of on the long side, or the median is a bit longer than the ulnar, but it's not quite enough to go outside the reference values. But when you add the 3 tests together, then your sum gets over 1 millisecond, and it would be abnormal. So if all 3 are at the upper end of normal and you add them, it might actually get you into the abnormal range and create a diagnosis.
Bill, is this just a Larry Robinson thing, or do you do it, or do you use that at all?
Well, can I start at my beginning?
Yeah, of course. Sorry, I didn't let you talk at the beginning. Go for it.
No, first of all, I have never made the diagnosis of carpal tunnel syndrome in the EMG laboratory in my 40+ years of doing EMG. Carpal tunnel syndrome, by definition, is a syndrome with symptoms and signs. There's nothing about electrophysiology in that definition. So we do make the diagnosis of median neuropathy at the wrist, which sometimes can correlate with carpal tunnel syndrome and the symptoms of that. The Palmer studies in our hands are 97 or 98, 93 or 94% sensitive by the data of Clark Stevens. And for me, that's good enough. I'm not here to get people to surgery. And in fact, in my mind, I don't want to overdiagnose something, because as Larry knows, the more tests you put into something, the more error you have in the results. So I'm kind of a simple guy. And so I don't use indices for this type of thing personally, but I appreciate the value of them. So that in general is the comment. And secondly, I would like to take a more specific history of this patient, because you said they have a numb hand. Well, patients mean different things by numb hand. And so I have seen plenty of patients that have come in with a numb hand who have an ulnar neuropathy. I've seen patients who have come in with a numb hand who have an abnormality of the duct, the dorsal ulnar cutaneous nerve, a branch of the ulnar nerve. I have seen people come in who have radial neuropathies. So getting a good history is really critical. And secondly, we see people who come in who really just have overuse and don't have anything else. So the history, I think, is really important in doing this.
Yeah.
And Bill, do you ever go to the extreme? I know it's extreme, to examine the patient before you do the nerve conductions?
I don't get paid for that, so Larry, no, I'm sorry. Actually, we are in our laboratories have been criticized because we don't report a history and in our reports. But in fact, I rely more on my history than the history in the record. Yeah. And I rely on my exam more than I rely on the record. Now, when I take my history, it's not sitting down with the patient, it's talking to them as we're going through the process. And so I'm taking a history the whole time I'm with them. I'm getting historical information. And I also find this in my general practice, the less formal you are taking a history, the more information you get. And so I take a pretty detailed history, and I learn a lot by doing that. So yes, take a history. And yes, I will alter my examination based on that history. So I suspect this patient had typical is not the word, symptoms that we would consider with carpal tunnel, but I'd also want to make sure there's not something else going on.
And I would just say that, yeah, I mean, we obviously all agree of the importance of taking a good history and exam. But even when we do that, we many times have patients who have fairly vague symptoms like this, and they can't pinpoint that it's the first 3 digits, or their description of numbness is vague. It's an altered feeling. It's not loss of feeling. So, I think that does make it a little bit more difficult, and our need to rely on testing to help clarify what they are describing, whether there's objective evidence of a deficit.
I never allow a patient to tell me they're numb. I say, I don't know what numb means. Please explain to this more for me. And how often have you heard someone say they're numb and what they're really telling you, they're weak?
Right.
That's a great point.
Yeah. Yeah. So from the neurophysiology standpoint, so there are some other techniques. I'm just curious that if you ever add these in that are reported, such as segmental stimulation, right? So stimulating palm, recording from the index finger, and compare that to wrist to palm segment, or even inching across the carpal tunnel, which I know is technically very difficult, and there's shock artifact that limits that. But do you ever use those, or not really, either of you?
As long as you brought up the inching across the wrist, I will honor Dr. Jun Komura, who actually wrote about that and talked about that, and he technically was very good. There are times when we will become more specific and do some more specific tests, but it's not common that we do.
I would sometimes do the inching if someone, say, had a proximal median nerve injury, and the question was, the nerve is regrowing back down, but is it getting stuck at the edge of the carpal tunnel, at the edge of the transverse carpal ligament? And sometimes that's moderately helpful. The study where you're recording, say, long finger and stimulating at 7 centimeters and then 14, that to me is particularly useful if you have someone with a polyneuropathy and you're wondering if they have superimposed median neuropathy at the wrist. Because if the proximal segment is slower than the distal segment, then you're thinking, yeah, that probably is some entrapment at the wrist. You do have to be careful of temperature, because usually the distal segment is colder than the proximal segment. So you have to take that into account.
Could you just use your orthodromic palmars to separate that out? The two studies I showed, if the amplitudes are low, but you still have a relative prolongation of the median latency compared to the ulnar, would you be confident in saying that's median neuropathy, or does that data is it not accurate when you already have a diffuse neuropathy?
Well, I've spent a lot of time thinking about how you could actually do that study well to determine that. And I haven't figured it out yet because there are so many variables involved. But how many times have we come across the patient who has peripheral neuropathy, but also has prolongation of the median nerve? And do they have a superimposed median neuropathy at the wrist? I always say clinical correlation can be very useful under those circumstances. And I'll give you an example of a person with demyelinating Charcot-Marie tooth disease, where the values can be very slow to begin with and the latencies can be very long. They do get carpal tunnel also, and they do get symptoms of carpal tunnel. And so we've seen more than a few of those patients, and that compounds the whole issue. So I'll come back to the point, clinical correlation, good history is all part of what we do. And I think one of our mentors said the EMG is just an extension of the clinical examination.
One of the issues with, say, using the mid-palmar, in addition to all the things that Bill mentions, is that we don't know that the nerves are uniformly slowed down in any polyneuropathy. Maybe the median is slower than the ulnar in a given polyneuropathy. And like Bill said, if you look at people with diabetes or other polyneuropathies, there's a substantial portion who have slowing of the median nerve across the wrist, but they don't really have clinical symptoms of carpal tunnel syndrome, and you don't know what to do with that. And the other issue, and of course this is part of the same thing, is that the latencies don't reflect the same things as symptoms do. So your symptoms are from ectopic excitation, from conduction block, from axon loss. If your depolarization is a millisecond longer than it would be normally, and that was the only thing going on, I don't know if you'd be that symptomatic. I mean, if it gets to your brain a millisecond later, is that going to create numbness and tingling and weakness? I don't think so.
Yeah, it's good, great points. What about one more thing to think about, and I have a feeling I might know what you're going to say, but what about in this situation using ultrasound? So the conductions are normal. None of us are pure ultrasonographers, I know that, but conduction's normal, good story for carpal tunnel. Do you ultrasound and see if the nerve is large?
I think there is value for doing ultrasound. I know that there are many people who would be surprised I say that, but I think in this case it can be very valuable, particularly under circumstances where it's really questionable about if there's a problem with the nerve or not. And so I use ultrasound quite a bit in these circumstances.
Yeah, I agree with Bill. It might be, it may be helpful. It may add some additional information, but I think in the end, it depends what you're going to do with the information. How are you going to change management? So I know Jeremy Bland has thousands of patients in his database, and he's looked at the outcome after carpal tunnel release according to your nerve conduction results. And if you have normal nerve conductions and get surgery, the results are not good. So in a case like this, I would tend to say, you know what, even if the ultrasound is abnormal, doesn't matter. I'm still going to do conservative measures. I'm going to do splinting at night, maybe steroid injection if that doesn't help, but I'm not going to recommend surgical release, even if the ultrasound's abnormal, because
So
these
Larry,
guys won't do well.
do you think Dr. Bland had such poor results because most of those patients didn't have carpal tunnel to begin with?
Yeah, I think it's exactly it. So he had, it was about 50% had complete, 40 or 50% had complete resolution of symptoms. And it's a combination of a lot of them didn't have carpal tunnel to start with, so that's not going to work. And then if you look at placebo responses, we think of drugs as being about a 33% placebo response. But the more invasive the thing that the intervention is, the higher the placebo response. So injections are higher than drugs. Surgery is higher than injections. So that response rate is entirely consistent with placebo response.
So Larry, how often do you see complications from carpal tunnel surgery?
They're rare. They're rare. You get sometimes palmar fasciitis. Sometimes you can get damage to the nerve. It's not a high complication rate. But I think if you can treat it conservatively, you're probably better off. Occasionally get someone who rarely gets into chronic pain, or someone who they get angry about the surgery, they didn't get complete relief, and they just develop into a chronic pain syndrome. It's not common. And if you really have carpal tunnel syndrome, over 90% do quite well.
Well, those are terrific points. Anything else in terms of the evaluation you would add? I know, I like presenting a simple case that's not really all that simple because there's a lot to it and a lot of options. But for our viewers, any other points you might add about patients like this with mild symptoms?
Well, Devin, in the EMG laboratory, we do nerve conduction studies, and we have another technique that we use called needle EMG. Do you want to relate to that in this discussion, or should we just avoid that?
Sure, no. Needle EMG in carpal tunnel?
Yes.
You want to talk about, do you do it, and do you stick the thenar muscles in all cases?
Well, I'm old school, so the answer is yes. And I do it for two reasons. One is that sometimes you can have abnormalities in the APB, which I prefer, when the rest of the studies aren't very abnormal. And so that can help with the information. I recognize that some people don't agree with that. And other times, when you do have carpal tunnel syndrome and you find significant abnormalities, and what I'm referring to is fibrillation potentials in that muscle, to me, that takes it from, no matter what the nerve conduction studies are, to a severe case of carpal tunnel, because I think at that point really should consider a release, because you're losing the muscle. And it's hard for muscle in the intrinsic hand muscles when they reintegrate to come back to where they are. So I would not want to lose anymore under those circumstances.
And I would do it under three scenarios. So one, if there was a setting of trauma, say after a car accident, people had symptoms, that's where you might have a higher likelihood of axon loss. It's not that slow, steady progression of demyelination that gets worse and ultimately axon loss, but you might have axon loss right away. And then the second would be where your median motor latency is significantly abnormal in the absence of trauma. There you have a higher yield. Or third, if you're thinking some other diagnosis like cervical radiculopathy or plexopathy, then it would be worth doing the needle EMG. Absent those three conditions, I generally don't do the needle EMG because I think I personally feel like it's low yield.
Yeah, I would just add, there are a number of studies, maybe you've done some looking at the, I guess, positive predictive value of abnormal needle EMG relative to the nerve conduction studies. We did one a number of years ago. It was a fairly small study, but we made it simple and said we separated patients based on an absolute prolonged median motor latency or a normal median motor latency. And if the median motor latency was normal, we had a very few patients that had abnormalities, and the abnormalities were more on the lines of some increased turns, maybe one fibrillation, so pretty minimal. And so I agree. I don't, if the median motor study is normal, I don't usually perform the needle examination unless there's something unusual about the patient.
Well, I feel that in the position I'm in, I'm looking for unusual things, and I can't find them if I'm not looking. So I'll give you an example of just last week. I saw a patient with had carpal tunnel syndrome, had a normal median motor latency, and I put the needle in the APB, and there was this repetitive discharge that I call a myokimic discharge in the APB, which tells me there was some involvement of the motor branches of the median nerve, because we know that you can see myokymia in carpal tunnel syndrome. And I did point that out to all the people in the laboratory, as you can see anything if you look for it. But if you're not looking, you won't see it.
Well, it might be fun in some people just to do every muscle. I'm sure we'd find a lot of really interesting things too.
Well, I agree with you actually that it would be, and it's surprising what you see sometimes. But I would have to have some clinical reason for doing it.
Sure. Yeah, we don't do it, even though we enjoy it. Patients don't enjoy it. So
there are particular muscles I would like to examine on particular people, but there's no clinical indication for it.
yeah, right. Well, this is terrific discussion, and I think it's very useful. I learned from both of you. It's always good to hear different perspectives on how we approach what seems to be a simple problem and isn't. And it's great to hear both of your thoughts. And I hope that our viewers, I'm sure our viewers will learn from you, as they always do, not only an EMG talk, but anytime you both talk.
Well, Devin, thank you for inviting me and also Larry, and we really appreciate having the time to do this. Larry and I don't talk very much except at EMG Talk, so it's nice to see you.
Yeah, same here. Really appreciate the chance to talk with you and with all the viewers.
Yeah, well, it's great. It's great to see you, and thank you again for taking your time out of your day, and I hope we see each other again soon.
Okay.
Bye.
Bye-bye.
I know.